All right. Good morning, everybody. Welcome to the January 2025 EQUIP subgroup meeting and Happy New Year to everybody. I think you're still allowed to say Happy New Year on the 17th. And I haven't seen most of you till now, so I'm going to go ahead and do it. Um, before we get into the meet, I was going to let Melanie from the Maryland Healthcare Commission give us a quick plug for the Practice Transformation Grant. This is the MHCC Practice Transformation Grant. It is different from the EQUIP Practice Transformation Grant that only EQUIP people can apply for. This is open to anybody who wants to do it and is really an opportunity to get into value-based care. So, Melanie, do you want to go ahead and give a quick discussion of it?
Yeah, so thank you for giving me a few minutes this morning, Jean. So I just want to remind everyone, we do, as Jean said, have a practice transformation program that helps practices to get ready for value-based care. We have 10 practices that just started and have 10 new practices. So they're just now doing their baseline assessments and getting ready to do their workflow redesign. So if anyone is interested in getting some free support, the practice transformation coaches are provided by MedCai. And we've gotten really great feedback from the practices who have been through it and say that it has shown them a lot of things that they wouldn't have otherwise been able to come up with on their own. So thanks again. And anyone can just reach out to Jean or myself. Thank you.
All right. We first thing I wanted to do because I know that we're starting a new performance year, so we have people who are maybe new to the group. Was going to do some introductions real quick and let you know who the players were. So I am Gene Ransom. I work for MedCai, and I'm the volunteer chair of this committee, and that's who I am. And again, I'm always willing and able to help out. We have with us from the HSCRC, Krista, who is the Deputy Director of Payment Reform. So she is one of the key players in EQUIP and in a lot of the other value-based care programs as well. On the CRISP side, who principally manages the reporting and all the other stuff, we have Kim Dixon, who's a program manager, and her voice actually sounds worse than mine, so I don't think we're going to hear from her a lot today. We have Crystal, who's a program analyst. And then, of course, we have Jessica, who we all know and love, who is the Director of Engagement Strategy now. Congratulations on your new promotion. And then the other staff person who works on EQUIP, who many of you have worked with, is Olivia Simon, who is an EQUIP Practice Transformation Specialist, and she technically is employed by MedCai. So those are kind of the players. And again, you can reach out to any of us, Kim, Crystal, Olivia, Jessica, or myself if you need any help or are having problems. If we're not the right person to help you with whatever it is, we'll figure out who it is. One of the really cool things about this program, and I've worked for MedCai for a long time, and just shows, I guess, that I'm old. A lot of programs are very much driven by just the state says this is what you're going to do, or there isn't kind of a collaboration. One of the really cool things about this program is from the very beginning, it's been a collaborative effort where we've had input from the private sector, from MedCai having a major role in running it. We've had the CRISP, which is a nonprofit that runs the HIE, involved to do kind of like the striped shirt analysis and be fair and make sure that the stuff is easy to report. And we have tools that help us be successful. And then we have the HSCRC, which actually makes the rules. By having all three of us kind of work together, I think it really makes the program stronger and better. And I think it's something we should be proud of. And for those of you who are new, I just think it's helpful to understand why there's three groups of us involved and why it's not just one place you go to necessarily to get help with it. But the diversity of the organization makes us stronger, and it's something we should be proud of. So we have a really busy agenda today with a lot of big stuff to go through. So I will stop my yammering, as my daughter says, and I will turn it over to Jessica to quarterback the rest of the meeting. Jessica, it is all yours.
Thanks, Jean. Yeah, we actually have a fairly full agenda today. We're going to start off with inviting some consultants that CRISP and HSCRC worked with, Dobson and DaVanzo, who did a wonderful analysis and deep dive on the first year of EQIP performance results. And then we'll go, as we are starting the season, where we're going to be managing a lot of parallel performance years, each one sort of in different phases. So we'll talk about where we are from enrollment and really the start of performance year 4, which is this new calendar year. data releases for last performance year, this upcoming performance year, and then really starting to drive any type of episode development and some policy discussions as it relates to PY5, which is calendar 2026. Crazy, but we already do need to be talking about it and working towards, some decisions that come in sort of the spring timeframe to get ready for the next enrollment season. So with that, I'm going to hand it over to Sandra from Dobson and DaVanzo, and they're going to go through their analysis. And like I said, they've been wonderful partners to work with. We're really happy to share, to bring them on to share this results.
All right. Thanks, Jessica. Hi, everyone. Good morning. I am Sandra Agik, a senior manager at Dobson, DaVanzo and Associates, a healthcare policy consulting firm out here in Virginia. And today we'll be sharing our results and findings from a report that we conducted to evaluate the performance of EQIP. I do have on the line my colleagues. I have Al Dobson, president and CEO of the firm, and then I do have Michael Baines, senior associate at the firm as well. Al, I believe you're on. Okay.
Yes,
good.
I am. I'm here.
Great. All right, so we'll hear some of my colleagues chime in as we go through the slides. And so starting off, for the presentation, there'll be an introduction. We'll talk about the methodology, data, and approach. We'll talk about some key findings, conclusion, and next steps, and then we'll open it up to questions. Introduction, we'll start off with some of the key objectives of the study. So we were asked to review and present the results of the first performance year of the program. And what we were doing was looking at the analyses that HSCRC conducted, replicating them and making sure that the math was sound, and then pairing that with a literature review to compare what the results from the program look like and other bundled payment programs that exist and studies that have been done on them. We also took a look at the choice of the methodology and sort of tried to understand if the analysis was done differently, how may have that impacted the findings. And so the key features of the program, I know that most of us in this room know most of these aspects of it, but wanted to highlight here that as we're thinking about evaluation, some of these things are very important in how we think about savings. So participation, for example, this is a voluntary program. Anyone can choose to participate. And I think from the evaluation perspective, if you're looking at a voluntary program, there are considerations around, is it selective participation? Are the people that are choosing to join same as the people that may not join the program, for instance? Spending targets, this was based off of 2019 data trended forward using market basket and other update factors. Again, that comes into consideration once you think about evaluating whether the program is generating savings or not. A few other aspects, so there's no risk adjustment in this program. And then the episodes we were looking at were performance year one episodes. We know that the program has since grown, but for the purposes of this report and work, we were looking at those three specialty categories, so orthopedics, cardiology, and gastro. And then on the risk sharing side, as we all know, upside risk only, you're held accountable for the savings with future savings, as well as if there's 2 consecutive years of the savings, then potential removal from the program. And then there's that minimum savings threshold of 3%. And then finally, on the shared savings side, there's a tiered based portion of earning for the portion of savings, as well as the tie to the 3 quality measures. So again, highlighting here that these are some of the things that we think about as you start to put together an evaluation for whether a program is making savings or not.
Sandra, can you go back to that slide, please? One thing that I think we've come to believe is no risk adjustment is too strong. There's partial risk adjustment because it's pre-post design, and it seems to work pretty well. So I think in our minds, we should not say there's no risk adjustment, but there's partial risk adjustment, and it's pre-post, and it's pre-post because the spending targets are based on the 2009 data trended forward. Took us a long time to get there, but I believe that that's a statement we can make now and you'll see how that plays in as Sandra goes through her presentation. Thank you, Sandra.
Fair enough. right, so methodology-wise, we got data at the episode level, so the data already grouped by Prometheus, giving us information on the spending as well as utilization. So the 2 years we're looking at is performance year one, 2022, and then we're comparing that data to the baseline year trended forward, 2019. And as I've mentioned, our approach was replicating what HSCRC had decided to use to derive those savings, and then pairing that with what are other programs showing our results sound. On this next slide is a more detailed stepwise approach of what that methodology looked like. At the high level, you're basically comparing for your entity, what did you spend in performance year one to what the 2019 spend was, trended forward by those update factors. Analytically, in 4 steps. One, at the episode level, right, for each category, we're looking at how much did you spend in 2019 trended forward, divided by the number of episodes at baseline, which is 2019, to get for each episode category what that target price is. And then in the second step, you're sort of aggregating that to your entity and summing that up to come up with an aggregate target price. In the third step, you're also looking at performance year costs. You're summing that up to have your comparison point. And then finally, in that last step, you're comparing for performance year minus the target price set within your entity. What does that look like, and were there savings? So then jumping onto the key findings, again, as I've mentioned, this is a replication of the analysis that was done. I'm sure some of us have seen these results before, but continuing to emphasize that when we're looking at positive savings, so if we look at just the entities that generated positive savings, we were looking at approximately $20 million. The percent savings depends on your denominator, right? So if you're saying $20 million for the entities that saved, that's about 7.7%. If you're looking at $20 million denominated on all the total target costs, that's about 5.1%. And then if you're looking at everybody combined, the savings were about 12 million, and that would be about 3% of total target costs. So somewhere around the ballpark of 3 to about 8% is what the savings rate looked like for performance year one. And when we compare that to the other programs that we looked at in the literature, when we're looking at CMS's bundled payment initiatives, for example, that cost savings ranges from 3 to 5%. For BIPC2 specifically, we know that we've seen savings of about 3% for hospitals, and then about 4.9% for the physician group practices. So seemingly sort of the savings that we're seeing from the EQIP program are comparable to some of the results that we're seeing in the literature. You know, some of the other programs are different. There's different ways of definitions, but I think for the ones that we think are most comparable, the results from the program seem within range.
And the techniques to determine them are quite different as well. We still get roughly the same results, which I think is important.
Mm-hmm. And then moving on to distribution of savings by episode category, the table on the right shows the different episode types across the board. So positive here is the blue shading is positive savings, and then the negative is the red. So as we can see, the orthopedics at the very bottom of the table, which represented the largest share, at least as relates to percent of baseline spending, appeared to generate the largest savings. I think if you look at across the board, orthopedics in aggregate actually had positive savings compared to the other aggregated episode categories, although there's some that have at least the sub-level episodes. There's some that do have positive savings as well. On the literature side, it does, compare and look similar when we look at other studies that have evaluated, for example, BIPC again. The procedural surgical episodes were more likely to generate savings. Studies have shown that for the medical episodes, it looks like one study showed that over time, hospitals and physician groups do start to generate savings, but maybe the takeaway point there is with experience, you do see savings with the medical episodes, and maybe on the surgical side, they're quicker to achieve savings. On the next slide here, by entity size, we've seen this data before. Here we're looking at practices with higher volumes of episodes. So the data, we took the data and sort of segmented it into 5 buckets, right? Depending on how many episodes you participated in. Quintile 1 is the group that had more than about 687 episodes, and then, 127 to 687 and so forth, just to get a sense for if you are participating in more episodes, or if you have higher episode volume, what do your average savings look like? And what we're showing there is sort of if you have a higher volume of episodes, you are more likely to generate positive savings. And this is our descriptive way of showing that. In the study, in the literature, there's similar trends as well. CJR, for example, an analysis showed that the hospitals that tended to be larger with a higher volume of procedures tended to generate savings. So very consistent with what we know in terms of course, if you have a higher volume, you're typically more likely to recoup some of those savings. And then this bit here, we did go a step ahead and also look at utilization. So for one of the indicators here, we looked at post-acute care utilization. And here we're comparing across the different episode types, what does post-acute care use look like following your episode? So cardio, gastro, orthopedics, and then we're looking at baseline year compared to PY1. Here we're showing that, at least if you look at orthopedics, right? So if you look at community, so those are the patients that were discharged straight to the community following their episode. It jumps from 50 to about 54.2%. And then the other important one, SNF, skilled nursing facility at the bottom, it drops from 14.8 to about 6.3. So this is showing us that, orthopedics, at least in the past slides, we've shown that they generated the most savings. Here we're showing that pairing that with utilization looks like some of the savings are being generated from the sort of avoidance of skilled nursing facility, dropping by about half, and then discharging more folks to the community following their procedures. And this is true in some of the literature that we've read as well. In one study, they showed that about half of the hospital savings were from these types of changes in post-acute care use.
And that's a pure substitution play where you reduce the stuff that costs a lot of money and you use stuff that costs less money, and in so doing, you save money. We've been working on that for years in our company, and it seems to hold. It's kind of obvious in a certain way, but sometimes the obvious doesn't hold. But in this case, it does. The expensive guys, they're targeted. And you'll see that the MA plans in Medicare are doing roughly the same thing. A lot of controversy around that, but they're doing the same thing. They're reducing their SNF care and doing everything they possibly can to put that care elsewhere.
Mm-hmm. All right, so then moving on to thinking about the analytic methodology. So the way that HSCRC chose to conduct the analysis on savings, what are the implications of that methodology? What are others finding in the literature? We have about 4 main points. The first one being, we know that if you're calculating savings using this target price, there's a potential for bias, right? There's a potential for self-selection. We talked about the voluntary nature of the program. There are other confounding factors that may come into play that may lead to either over and understating of the savings. And so one of our recommendations here is it may make sense to use a more rigorous approach, like a diff analysis that would compare spending pre-post, as well as use a comparison group to make sure that we're reporting savings and they are truly savings, at least based off of this approach that adjusts for some of those confounding factors. And then on the second point there, the lack of risk adjustment, if you go back one slide, please. Lack of risk adjustment. Al, as you pointed out, it's not necessarily that there's a lack of risk adjustment. Maybe there's a partial risk adjustment, because I think here we're talking about comparing an entity to its prior spending in the past. And in the literature, we've seen studies that have tried to get at this question. And it really shows, at least from the work that we've seen, if you are comparing an entity to itself in the past, you may not necessarily need to risk adjust because there's some sort of adjusting in itself. Now, in other programs where they're comparing an entity's spending to some sort of benchmark that's based off of regional spending or an average of regional and an entity's historical spending, then in those instances, it may be important to risk adjust. So at least our finding here, and I know that the choice to not risk adjust was informed on additional analyses, but our finding here is the literature does support some of that choice, that it may not be necessary given we're using the same entity's past spending. And then our third point here is the issue of selective participation. So we talked about how joining the program is voluntary, and there could be bias if the people joining are more efficient or more likely to generate savings. Then you don't truly know whether the program is effective at generating savings. And here, what we did in the first phase of this analysis was actually look at the baseline year comparing participating and non-participating providers, and then looking at the provider characteristics, looking at the patients that they served, and comparing to see, are there differences in who chose to participate and who did not? Are there differences in the types of patients that those providers were seeing? And generally, what we found was there were no marked differences. Now, in the report that we shared, there were, I think, a few differences that we noticed, but I think in general, what we concluded was there were no marked differences in the participating and non-participating providers. We have more detail on that, but at least our top line conclusion there was they weren't too different.
And we pushed that analysis pretty hard, and we went over it and added and spent a lot of time trying to take it as far as we could. And we just couldn't find anything terrible in terms of the risk. It looked like it was working pretty well, even though theoretically you're not altogether sure that it would.
Yep. And then finally, the last point here from, our review of the analytic methodology is the use of 2019 data to calculate that target price may not be accurate, right? Like, we know there's a pandemic that has happened, and we know that it may have caused differences in case mix, differences in spending post the pandemic. And so, one question is 2019 data still the most accurate benchmark to use as a target price? And the further away you move from 2019, sort of the bigger that question comes. So that's the other conclusion that we came out from looking at the analytic methodology here. All right. I think in summary, that's it. The report is more detailed, but we thought today we'd share some of those high level findings. And at this point, I'll stop and open it up to some questions.
Thank you, Sandra and Al and the whole Dobson and DaVanzo team. You were wonderful partners working on this analysis. I did drop in the link, the Learning System website, which has the full report that they've produced for us. And there actually was a question, and it sort of piggybacks off of number 4 in your sort of observations and impact, sort of related to how new innovation that likely could be more costly is integrated when we're still using the comparison year as 2019. And I think that sort of was reflected in your response as we move further and further away to 19, there certainly are some considerations. From a strict methodology standpoint right now, in the current state, that really isn't accounted for. We are looking at straight 19 costs, inflating them forward. But if there are substantial clinical changes that really don't make that reasonable, or I guess opens up for conversation, it's certainly something we should look at. And it's a little sneak peek. We're going to start some of that conversation. One of our last agenda items is opening discussions about looking at that baseline year as we look for calendar year 2026 and forward. There weren't any other questions in the chat, but if there are, this is pretty informal, so if anyone wants to get off of mute and ask any questions to this team. Okay. Well, we're not seeing any questions. Thank you so much. Like I said, Dobson and DaVanzo were wonderful partners. The full report is published, and if there are any questions, you can, forward it up to the EQIP inbox, and we can always filter it on down if needed.
All right. Thank you.
Okay. Thanks all.
Bye.
I'm going to hand it over to Crystal, and she is going to talk about where we are from performance year 4. So just started, 17 days ago, but there was obviously a lot of requests and contracting that went on towards the end of the year, especially around the holiday season. So we wanted to give everyone an update about where we are there. So Crystal, I'll let you take it away.
Good morning, everyone. So we're just going to get right on started. So in this slide, we kind of have a quick table overview with some of the key data points from PY4 enrollment. So as we can see, in total, we have 128 EQIP entities enrolled with a little bit over 3,300 care partners. And within these specific entities, we have a variety of about 38 specialties. Now, our smallest entity is 1 care partner, while our largest entity is 244 care partners. And then to the right of this slide, we just have the clinical episode categories that were available alongside the number of entities, EQIP entities that enrolled in these categories. And as you can see, we have a variety of different clinical episode categories and a lot of different EQIP entities that are enrolled in each. So we can go to the next slide. Now moving on to CPA compliance and the probation status for EQIP participants in PY4. So following enrollment, we made sure that all care partners participating in PY4 had submitted a care partner agreement. And for any care partners who did not submit a signed care partner agreement, they were removed from participating in PY4. And so for the PY3 care partner eligibility, any care partners who didn't touch a claim during performance year 3, quarter 1, and quarter 2, which would be January through June, those care partners will no longer be able to be eligible for PY4 and not be able to participate. And so these care partners do have the opportunity to re-enroll for performance year 5, which will be calendar year 2026. And the EQIP team did send out emails notifying all the entity POCs of this deletion for their participating care partners. And then if you would also like to view your finalized care partner agreement status, please just refer to the EQIP entity portal as it is finalized and updated with all that information. And I just want to note that there's nothing additional that any entities will need to do in regards to anything mentioned on this slide and the following slide that's about to come up. If you could switch slides, Jessica. Okay, so the last step for the EQIP team would be to just complete all the final eligibility. And so since care partner lists have essentially changed from the end of enrollment, which was September 1st, to now, we had to make some edits. So for example, the volume threshold may now be a little bit different due to unsigned CPAs or any physicians that may have retired from your entity. So we are currently making those changes to any entities to make sure that they fall just at the appropriate volume threshold to participate in PY4. And then for care partner probation, any care partners that did not touch a claim in the baseline year of 2019 are now on probation. So those care partners must touch a claim between PY4 between quarter 1 and quarter 2, which would again be January through June, to be eligible to participate in PY5, which would be calendar year 2026. And we'll also be notifying any entities whose baseline quality metrics fall in the lowest decile in the state. So entities that do not meet the minimum quality performance in the first half of the year, January through June, will then be placed on probation for PY5. And all entities will be notified through email on Friday, January 24th by end of day, usually including their baseline data as well as any quality information. And that will also be available in the e-reporting suite as well. And that's all for me. I don't know if anyone has any questions, but if not, I'll pass it over to Jessica.
Thanks, Crystal. And thank you everyone for, herding cats and a lot of getting back and forth between some updates within the CPA process. We know it's a lot, and there's really happy about the increase in enrollment status. And we really, again, appreciate everyone's, especially the administrative staff that sort of help, shelter that along. So the other question now we've gotten asked about where data, we're really excited. The new year has started. So what's going on with data release? Just to back up a step, I want to talk a little bit about where the data come from, because that also impacts sort of the timeliness of the data. So as a reminder, performance, baseline, quality metrics, everything that we use for EQIP is derived from the claim and claim line feed. That's what we call CCLF file. We get that, or the state gets that from CMS the month after, the month following, the close of the month. So for example, we'd get a January file from CMS in February, that type of thing. And just as a note, currently the EQIP suite only publishes final completed episode data. And what we mean by that is that in order for data to be available and what you are seeing in EAP, the episode has to have completed and we have finalized the claims run out, which is typically 90 days. So the timeline from start to finish of that is variable based off of the episode length. But we want to ensure that we're giving, or what is published is accurate data and isn't misrepresentative of only like half of an episode and could potentially show someone, being favorable because there aren't all the claims that are in the system. So we want to keep that in mind. Also, right now, the current system has PY3 data just the first 2 quarters. So we will be finishing up PY3. As a reminder, that performance year does use the Prometheus grouper. The Prometheus grouper is run by Change Healthcare. It's their proprietary grouper, so they run it themselves, and that's why it's released quarterly. So there's going to be 2 more releases to get the final PY3 data. However, starting this year, for performance year 4, we moved to the PACES grouper. One of the great things about moving to this grouper, it has allowed CRISP, HSCRC, our partners, Hmetrics, to actually run a monthly data release. So we're really excited about that, and we're talking about how that impacts and shortens some of the delivery time for the episodes. And then the other new thing that was added or will be added, and again, this is a great thing that we're able to do now that we can run the own grouper, we can run the PACES methodology ourselves, is in the EQIP portal starting PY4, there will be a preliminary trigger beneficiary list. And what that means is while final completed data does take a while, we will make available a preliminary list of episodes that have triggered in months that have passed. So you might not be getting the full amount of data, but you are getting a little bit more information. And again, as we start with PACES and continue sort of this development, our goal is to get more information timely, as we can, knowing that it is claims data and it does require some time for it to be finalized. So what does that mean, exact dates? So again, this is a tentative release schedule. We always say tentative because there is a level of Q&A that goes into every release. So if there is something that we want to, take a little bit more time to ensure accuracy before pushing it out, there can be some fluctuation in these dates. Typically the month, when you have the months here, the actual date is towards the end of the month. Like think of the 4th Friday, it's typically, but that's really the time that it's released to everyone. So from the Prometheus side, as we mentioned, there's 2 more quarterly releases. Episodes that have ended in Q3 of performance year 3 is going to be in a March release. So towards the end of March, you'll get that update in the portal. And then final data episodes ending in Q4 will be released in about June of this year. Again, there may be a little bit of changes. I think last year was published like the first week in July because we wanted to have that extra level of quality assurance. Holidays, things like that does impact timeline. As it comes to PACES, so now we're in this current year in PY4. So the baseline data will be available in February. Please keep in mind, because the CPA process took a long time, we can only run the data when we know the final composite of all of the MPIs that are actually participating in this year. So that was really just finalized pretty much early this week. So you'll be seeing that data available for you in the February release. And then let's walk through and we'll go through examples of when other release schedules will come out. So episodes that will end in January, there's probably only a few of those, that will happen, especially for our shorter episodes. Those will be available in the June release for the EQIP portal. And then you can kind of see, that pattern will follow. But wanted to point out, when we look at the end of the total year, so episodes that end in December of 2025, that should be available in the portal in February of 2026. So we have, and we're really happy and optimistic that we'll be able to shorten that turnaround time. We were looking at June of the following year as best case scenario to get you data for Prometheus, and under PACES, that would be available in the February timeframe. Now, I'm going to walk through 2 different example episodes because I think sometimes all these dates and months, they kind of seem a little bit off, and sometimes people think of trigger date versus close date and things like that. So I wanted to walk through 2 examples, a 14-day episode and 90-day episode. You can kind of see what this would look like. And again, this is for PY4, so under the PACES grouper. For a 14-day episode, let's just say that it was triggered on January 15th. All 14 days of that episode does complete within the month of January. So in the month of February, March, and April, you're looking at that claims run out. So we're getting additional claims, making sure that it's a full, complete, and accurate representation of the services that were offered. However, in the March release, that's when you will be able to see a list of preliminary trigger bennies. And we do say preliminary here because there could be things that change as far as eligibility. As you know, attribution for chronic episodes does also change throughout the year. So again, it's preliminary, but it does give you an initial list of bennies that are triggered in that January timeframe. So you'll see that in the March release. We get the file from CMS, the April file, in May, and then we turn that around and it will be delivered to you in June. So in the June release for the EQIP portal, you'll be able to see the final completed episode data for all episodes that were completed in January. And in this case, this 14-day episode. Now, this is going to look different when episodes are longer. So let's take that same trigger date for a 90-day episode. So it's triggered on the 15th of January. You can see that because it's a 90-day episode, it actually does not complete until the middle of April. Again, you would still have that preliminary trigger beneficiary list available in March, so you'll still be able to see potentially the patients that were triggered. But that claim run out ticker does not start now until May. So it opens in January, it closes in April, May, June, July is when the claims run out. CMS sends the state the July file in August. And again, that is processed, run through the grouper, and pushed out to the portal in September. So those are 2 different examples. Again, we're happy to walk through additional ones if needed, but hopefully that can serve as a basis for as you guys are looking at when is data released. Please keep in mind, we're always continuing to look at opportunities. We're in conversations with potentially looking at other data sets that maybe could assist in notifications of early triggers and sort of things like that. But we're really happy that at least the PACES grouper has enabled some improvement on this, the claims turnaround time here. I will pause. I'm not seeing any questions in the chat and no hands. Okay.
I'll just say, Jessica, that the getting more data sooner is something, I mean, obviously this isn't perfect, but it's a lot better than what we're getting before. And I think that I've heard that from a lot of physicians who've expressed concern about it. So this is definitely a move in a better direction, and really appreciate you guys doing the work to get us there. And I think I'm speaking for a lot of docs that have just said, hey, the more data, the sooner we can do a better job.
Certainly. I see a hand.
Go ahead, Jill.
Yeah, that's me. I'm Jill Rockbeisel. So I'm part of the brand new behavioral health episodes this year. And those, if I understand it correctly, those episodes are year long. So do we get notified of a beneficiary list periodically? But I wouldn't imagine we'd get anything until the very end of the year. Is that right?
So chronics handled a little bit differently. So we'll, one, you would get the beneficiary trigger list, same sort of thing. You would know if they're triggered in January. I would say specifically for chronic ones is probably where you'll see a larger difference in that preliminary list month to month, because, you know, as E&Ms change, that attribution of that Benny could change throughout the year. And this actually is something that is updated. So you would be able to see it in each monthly update, but we did want to make sure again that that's one that we want to be very conscious of how that's interpreted, because you could be looking at, you know, 2 months worth of data comparing to numbers that are 12 months. Of course, it's going to look really great. So you will start seeing that, but you probably won't actually be able to see or I would say I would recommend not taking the early data releases with a grain of salt as you look at the maturation of that throughout the months. But you will be able to see something. We're not letting you go blind for that entire time until February. But that one, again, all chronic diseases or all chronic episodes sort of will have that same pattern. You'll be able to see it, but it'll be development. And again, that preliminary target list may change. You'll probably see significant changes, especially as the year is in the early part compared to when it's towards the end of the year.
But Jill, one of the things, like, for example, that you can see is like, are your practitioners not hitting the quality measures? And then you can make an adjustment. And, you might see if you have a practitioner who's an outlier doing something unusual, maybe less so in your particular conditions, but in others, you might see something. So it is worth, really looking through that and thinking about it. And while obviously it doesn't tell you the entire story, it tells you part of a story that can be helpful.
Thank you.
Yeah, thank you. PY5 episode development. So as I mentioned, PY5 calendar 2026, but yes, we are already in the midst of our episode development timeframe. As a reminder, sort of back in fall and winter, we started introducing this. I know, MedChi has done a great job really talking to medical societies and other key stakeholders that they're aware of, trying to help distribute some of the opportunities to add episodes or add net new specialties for EQIP. So really in the fall timeframe, it was letting people know about that. We'll share a little bit of some concrete episodes that people have requested. And really in this winter timeframe, we're going to work through the design of that, ultimately leading to CMMI approval. And then spring timeframe, we're already in recruitment season because starting in July, the portal opens, and especially if we're adding new episodes, we want to ensure that there's actual participation in those. So back in November, we distributed the finalized PACES episodes. And what does that mean? Because PACES does have a total catalog of about 1,000, I think, plus episodes. Some of those are in various states of validation for them. This on their finalized list, again, 266 is where this ended up, are the ones that have been fully vetted. They're finalized. They're sort of off the shelf, readily available to be used. So we distributed this and asked stakeholders input and said, hey, is there anything on this list that, your clinicians, your practitioners would like to add, or at least add for consideration for next year? And then we also asked if there is a gap, if they want to add something, but they're not seeing something on this list. Again, please let us know. So really, we are leveraging, we want to really kind of go all in on the PACES model. It's a new grouper. One of the main reasons that we chose to switch to PACES is because of its extensive catalog. So again, really trying to say, hey, is it in PACES? Can we make it work within the PACES methodology? If there's a net new episode, can we work with the PACES team to develop it again within sort of their logic and hierarchy? So with that, we actually got, and which is pretty exciting, about 88 new episode requests from that PACES list. So that 266 list, there were 88 episodes that were requested from it, and then 9 that were identified as these are areas we'd like to participate, but hey, we're not seeing them on the list. Again, just because we're saying all 88, I think our initial responses, we have to do sort of a first initial review to see if any of these make sense. There's the list here. It was pretty, I think, speaks well to sort of the growth of the program as far as the variety of specialties, or really they're calling it clinical categories here that you're seeing. We had areas that already are participating, maybe have 1 or 2 episodes available for them now and are looking to add more episodes within their specialty. And then we have sort of net new specialties, which I think also is exciting because one of our goals is to expand this into other areas. So you can see the list here really across the board, lots of variety. The first thing that we're going to do is take an initial review of it. In certain cases, while of course PACES has the episode defined, the grouper is there, it may not make sense from our EQIP methodology logic and the claim set that we're using. A couple things that stick out, as we mentioned earlier on, we use the CCLF data. The CCLF is only part A and part B data. Some of these episodes may be pretty heavy in part D as far as how they define the episode. So given our data set, it isn't something that probably aligns at this time to move forward with. Another thing is, of course, this is a Medicare fee-for-service program. There are certain episodes that were put on the table that we would likely see a very, very low volume for the Medicare population. Again, may not make sense to add. And finally, in the CCLF data, it is redacted. CMS already redacts that for certain substance abuse claims. So again, while PACES does define certain substance abuse, alcohol, opioid, there are other types of areas or episodes that they have. Again, it might not work well given the claim set that we use. So we'll review that. We'll reach out to stakeholders and let them know, hey, this isn't something we can move forward with it. It may be something that we want to open discussion for a different approach to for future years, but just letting you guys know that that is sort of the first step of digesting all of these 88 requests. After we sort of narrowed it down, those that we are looking to explore and move forward with, we will make the episode playbooks available to the requesting stakeholders, kind of get their feedback. Some of the requests were really more inquiry, like, oh, I think I'm interested in this, but I'd like to learn more about the definition. Whereas some, again, there's probably full confidence that they want to move forward with it. So as we sort of, narrow down the list, get stakeholder feedback, we'll be sharing at future subgroups, what a new list for episodes that actually might move forward for the next performance year. And the new episode development. So there were 9 different episodes that were suggested, again, that were not seen on the list. We've already sort of run this through the PACES team. And as mentioned, we shared 266 of their 1,000 episode catalog. So what was good to hear is that 7 of these 9 episodes already do exist in the PACES world. They may be in different levels of finalization, so there still may need to be some clinical input in order to get them sort of across the finish line and make them usable for next year, but the structure is still there in the PACES area. The remaining 2 are not. The initial response from the PACES teams thought that they would fit well. So we will likely need, in order to get those sort of, again, available for use, we will require input from clinical experts to assist the PACES team in actually building that out. Again, we'll reach out to those people that did the request, and if we want to open it up for other people who may be part of that clinical expert team, we welcome that. I think last year the behavioral health episodes led by Dr. Rocca was a prime example of how we used input and an expert from this group that directly resulted in a new PACES episode that could move forward in the year. So we've done before. I think again we want to continue with it and just
Jessica, which episode specifically do you need the clinical help on?
Alopecia and vitiligo, I think. You put me on the spot. I'm pretty sure it was those 2, but we have the initial person that requested it, Jean, but then I'll ping you because PACES likes to have at least 2 people if possible.
Yeah, and the palliative care you do not need. We have a practice that reached out about palliative care after the deadline.
Yeah, we may need it. So sickle cell disease does exist. The framework of it exists within a PACES episode already. We are having some further conversation of like getting to the root of exactly where each of these episodes fall and sort of what are next steps with them. The good news is it's not every single one needs built from scratch. Some of them might just need some eyes on it and say, hey, does this look good? Other ones might need a little bit more work. So Jean will, of course, work together on all of those that will need input because there'll be some clinical expertise that will have to review it.
Great.
Okay. And yeah, Chris was aiming to sort of kind of get this together in the late January, early February timeframe because these can take quite some time. We've seen short ones that are quickly turned around and other ones that, take a couple months. So we want to be mindful of our timeline, really spring, having that finalized list to get it ready. And again, make it available in the portal for you all for next enrollment season. Okay, I'm not seeing any hands. Okay, for the practice transformation grant, and I know we've used this in a couple different ways. So this is the EQIP specific practice transformation grant. As a reminder, this were for participants for this upcoming year that had participated in prior years and had not seen savings, whether they saw savings in performance year 1 or year 2, or at the time for performance year 3, they were like not aware of how they were doing or only had a very small amount of data. So all new PY3 entities were available to apply for this. We had put out an RFP. I want to say we got like 11, something around that, 10, 11 vendors that did respond to it. And we have whittled up down and carefully chosen 4 different vendors that will serve as options for practices to use in this practice transformation grant. Again, they were selected based on their expertise, their experience, some of them working with specialty care, primary care, and they're really, I think, going to be great partners to work with. As we look at what's next here, so it was sort of a vendor selection. So we had a list of these vendors that were available. There are 29 entities that ultimately will end up moving forward with the grant. That does encompass just shy of 70 practices. So a fair amount of people, again, specialties represented across the board, and different types of procedures, chronic procedures, chronic episodes, procedure episodes, and acute episodes. So it'll be a great representation of some best practices that we can bring back to this group and share. So we, again, finalized sort of that matching or selection between the entity and the vendor just last week. We're communicating with the vendors on this and essentially working on that contracts. Our goal is to have this align kickoffs with right around that February data release, because most of the groups will be looking at their baseline as a starting off point. Again, that'll be available late February. All of that will be aligned. So you guys should be hearing from us right now, more behind the scenes that CRISP and the vendors are working on to get everything in place, contracts and stuff like that wise to kick off. So aiming for that February timeframe. If there are questions, also email us. I think everyone has been sort of communicated that they're in the program, what their vendor selection is, and stuff like that. Okay, so that is all for PY3 and PY4. And we talked a little bit about PY5 episode development. The other big thing are some potential policy updates or considerations for PY5. So with that, I'm going to hand it over to Krista, and she'll talk about considerations for rebasing.
Great. Thanks, Jessica. Next slide. So I wanted to start off by one of the policy changes we're considering is options for updating the EQIP baseline. I want to say right off the bat that we recognize that this is a significant change, and we won't be making any changes without substantial stakeholder input. So we are just starting these discussions and bringing in experts. So I just wanted to, start the discussion by saying that. And if a change, if made, would apply for 2026, as Jessica mentioned, these are 2026 policy changes. We are thinking this could be voluntary or mandatory, could apply to all episodes or only some specialties. So we're really looking at all of the different options for how to appropriately rebase. Given that the current EQIP baseline period is 2019, I think we're looking to potentially update that for various reasons. And we are modeling that impact. And again, we'll continue to share with this subgroup and also pull in experts outside of this group. So if you're interested in having a discussion, if you're interested in talking about this more, please reach out to any of the folks on the line today. So the reasons, again, we're considering updating the baseline is the baseline period will be 7 years old for performance year 5. Again, at 2019, we're looking at that being 7 years old. Provider churn is another issue. We have an influx of new providers. So EQIP requires that 75% of the providers participating have data from the baseline period. And so I think the provider churn is another consideration. And there are other policy changes that could address this issue, the provider churn issue, but the baseline is one of them, changing the baseline. The availability of post-pandemic data. Data from 22 onwards reflects the current healthcare delivery system, especially regarding service location mix. So the availability of data is something else we're considering. Program design, so reducing payments relative to site of service mix changes where there has been considerable change outside the program. We're continuing to try to ensure performance under the total cost of care model and the savings targets. And the evaluation results with matched cases and controls may highlight challenges with using outdated baselines. So these are all sort of program considerations that we are bouncing around. And as a note, the AHEAD model, which folks may or may not be familiar with, that the state of Maryland signed with CMS beginning and starts in 2026, uses a 2023 baseline. And so we are just kind of anticipating we might get questions from CMS at some point about kind of aligning our baseline years and not using baselines that are outside of that 2023 baseline. Again, this could be a potentially significant change. And so we want to underscore again that we are not making any changes without substantial stakeholder input from this group and other technical advisory groups. So with that, we can go to the next slide. Oh, okay. I don't know if folks have any questions on the baseline, or we can, I can hand back to you, Jessica.
Can I just make one quick comment, Krista, on the
Yeah.
one of the other issues we run into with 19 being the baseline that you mentioned quickly that I would just like think we should talk a little bit more and flag for people
Mhm.
is this problem of the practitioner who starts practicing in 2020 or later, that they will obviously always have zero attribution in the baseline and it creates a problem. So I just, again, and I've communicated this to you already before, and I know you know it, I really think we should separate that issue out and try to figure out a way to address that because if we could, simply, and again, I floated the average of the EQIP entity as the baseline for those folks. I mean, as long as we don't want to exclude people who are practicing and seeing Medicare patients and want to participate. So I just hope that we can maybe work on both issues simultaneously. So if we can't solve one, maybe we
Mhm.
can solve that one as well. Just, if, you know what I'm
Yep.
saying?
Yes, totally, completely understood, Jean. And I think we are considering that as we consider these changes to the baseline. Absolutely.
Because I think that's more important. The key is we really want to get everybody to participate,
Yeah.
and the more people we have participating, I think CMMI will look very favorably on that. I think one of the beauties of our whole model is the fact that unlike a lot of the other models, we've managed to somehow get alignment from people outside of it. So, uh,
Yeah.
and I think if we can get more, it's even better for us.
Absolutely. And we certainly don't want to pull the rug out from providers that are participating and, really working hard on this work. So I think we want to do what we can to balance, appropriate changes to match the data and deal with the data issues and provider churn, but also taking into consideration that folks are successful under the program and we don't want to, again, pull the rug out from under folks. So um,
Well, I just also, takes back to what I said when we opened the meeting. What I really appreciate the way that you guys do this, because HSCRC, really, you guys are the law. You're the ultimate authority, you and CMMI. But I really appreciate the fact that you tell us stuff way in advance. You do it in a collaborative fashion. You get input. You've done a good job with the transparency and working with everybody on EQIP. And I mean, I think that's a testament to you, Krista, and Will, and everybody else. But I just really appreciate that. And I appreciate the fact that you're talking to us when you're thinking about it, not once you've decided what you're doing and you're telling us that's what you're going to do, because we all want to help solve the problems. I think the problems you're outlining here are all legitimate, reasonable problems, and if
yeah.
we all work together, we can come up with a good solution, hopefully.
Yes, absolutely. I see a question from Rodney Taylor. I guess this is just something for consideration. How is it dealt with when new, more costly innovation is integrated to clinical practice subsequent to the comparative year? I don't know if anyone on the line can answer that, but certainly I can take this. We can bring this back and consider it as part of the rebasing conversation.
Yeah, I think it's a good note and comment, and
Yeah.
maybe in one of these reasons, or as we look at certain specialties or certain episodes,
Mhm.
maybe that should be considered because some may have
Mhm.
significant, clinical changes that 19 just isn't a great
Mhm.
representation.
Yeah.
Right. And I know, Chris and I spoke with the ER, a couple ER doctors who were saying that using 2019 is tough for us because of COVID. So, there
Mhm.
are like these unique considerations that we need to think about that make this also
Yep.
complicated. So it's not
Mhm.
all, and Rodney's point is legitimate. If for some reason some new Part B cost or hospital-based cost that's included gets added in, all of a sudden
Mhm.
your chronic condition or your
Question.
bundle could get blown up. So
Yeah.
it does work both ways. It's really a complicated issue.
Yeah, absolutely. Victoria? Would you?
Yes. Hi. I had a few questions just about going back to the previous section as well. So with all the changes that are happening with like the new episodes that are potentially going to be added and everything, I know for PY4 there was a delay in the enrollment window. So it was supposed to open, usually open July 1st. It was delayed to July 15th. Is that going to be the case for PY5 enrollment, or is it still expected to open on July 1st for this calendar year?
Yeah, good question. I think we always try to open as close to July 1st, also knowing that there's a holiday around there. So a little bit, it depends. I think that was our first year with PACES. So some of this and this early on conversation that we're having now are lessons learned. And as we talk about sort of this development timeline, especially for new episodes, that's something I think we're going to be very cognitive of, because as we push or are waiting on sort of final decisions, something else is being pushed. So certainly trying to aim for that July timeframe to give the 2 full months for enrollment. So hopefully that answers your question.
So in Victoria too, I also, if you remember last year, we were developing the two behavioral health episodes, which essentially were almost from scratch for all intents and purposes. We were crosswalking all the existing episodes from Prometheus to Paces, and we just had a lot of stuff going on last year. We were doing a lot of things, and I think some of those items caused us to have a little delay in opening it up. So I think the
Okay.
reason the deadline for what was to be considered in the application to CMMI was yesterday, or was it Wednesday? It was Wednesday, was because we're very cognizant of the schedule, and we know that, we have to vet everything and make sure that it makes sense. We, in some cases, will have to have a clinical review. We're going to want to do education and outreach videos by specialty, by bundle groups. So we've got a timeline this year that hopefully will work. But I think, given the workload and what we have to do and the team we have, I think we're going to open it up with plenty of time for people to sign up. And even by opening up on the 15th, it was still 45 days, which is a long time to sign up for the program. And the enrollment process is really not that complicated. CRISP has done a really good job building it out. If anybody's applied for other programs, they would long for applying for this compared to some of the other programs they have to apply for. So I think we're going to be in good shape this summer. I'm cautiously optimistic.
Okay, thank you. And my second question was just about like documentation concerning PY4 because it's already started. When I was looking in the learning system in the document section, a lot of the documents were from PY3, and with the transition to PACES in terms of like the specifications for the program, do you have a timeline on when those documents will be available for stakeholders to review?
Yeah, that's it's definitely on our docket and a priority for us to work on. I don't have a great date for it, but we are definitely going to push it, and we'll let everyone notify everyone it's in there. Hopefully, before the baseline data is released, so people can kind of absorb baseline as it relates to the policy side as well.
Okay, thank you so much.
But also, Victoria, remember there were no changes to the actual program. So, and the reporting of the quality measures is claims based. So, the most important thing to do if you're new to the program is to really make sure that you're implementing whatever clinical changes you've dealt with, and you've got a good plan on the quality measures so they're actually happening. And those are good things that you can do now, whether or not you have the new playbooks. And I would say that a lot of the material that Chris put together and those original playbooks is really good. And one other point on the enrollment issue, Olivia Simon particularly is available to help practices. So if anybody's aware of new practices who might want to do this or miss the deadline, have them reach out to Olivia now. We can start seeing what bundles you're available for now. We can help and start explaining how to do it. And I know she walked through numerous people during the summer. So that's part of what we do to help people participate. So we're happy to do that. And if you know people who aren't in it and want to be in it, the sooner they reach out, the better, because we can start to educate them and have them think strategically about what they might want to do as they sign up this summer for 26.
Thank you. I had one more question just about the data release for PY4 because there's a transition to PACES for PY4, and I know there were discussions about some of the, I guess, the data indicators being specific to Prometheus compared to PACES. Are there specific parts of the performance dashboard that are going to be changed with the PY4 data releases compared to PY1 to PY3 when it was under Prometheus?
Yeah, the only thing that really is Prometheus specific is the complications. So that was Prometheus methodology that grouped the three different complications in there. So we do have a replacement for that, but everything else is the same. And when data is released, we're happy to put on a webinar about the reporting suites because, as we mentioned, there also will be net new functionality available like this preliminary trigger at Benny list. So really from from the Prometheus to Paces change, there's really that only one consideration, but we also have added sort of feedback, sorry, from an enhancement side about sort of some net new functionality in the system. So we're always happy to redo webinars as it actually gets published and available. We do feel like webinars are useful when people can actually see the data versus, preemptively.
Okay, thank you.
I'm
All right,
answering
are
any
we,
other
is that it?
questions.
Is that it? All right. Well, everybody involved with planning this had a bet on the over under, and we actually hit the under pretty solidly on today's meeting. We thought it was going to run a lot longer. You guys have been calm and quiet today. So, is there anything else, Krista, Jessica, anybody wants to add?
Nope, just a reminder, next subgroup is in March. So people
So,
should have the series invite for the whole year, but it is in March.
all right. Well, everybody have a wonderful, wonderful weekend and go Ravens. I guess I should say go Ravens and go Commanders, right? For those of us who are not Baltimore centric. Go Ravens and go Commanders.